right now. Hello, everyone, and welcome to the November meeting of the Global Health Youth Organization. My name is Noralin, and I'm a co-founder of the organization. We're very excited to see everyone who joined us today, and we want to thank everyone for joining the meeting and working around any scheduling or time zone issues that you might have had. As for the format of today's meeting, we will begin with a quick introduction of our speaker, followed by his presentation, and then a question and answer session. After the Q&A section, we will post a shadowing certificate link in the chat. We ask that all members stay muted throughout the presentation so that we could limit interruptions and distractions. And please feel free to add any questions or comments that may arise in the Zoom chat. I will now be passing it over to Adam, the other co-founder of the organization, to introduce today's speaker.
Thanks, Nor. Hello, everyone. And as Nor mentioned, I am a co-founder of the organization. It is so great to see all of you that joined, and we are so happy that you're able to attend this meeting. We want to once again thank Dr. Meliker for taking the time to present today. To quickly provide an introduction, Dr. Meliker is a professor in public health at Stony Brook University. Dr. Meliker's current research interests are focused on exposure assessment and environmental epidemiology. Please remember to stay muted throughout the duration of the presentation to minimize distractions. Again, if any questions do arise, please type them in the chat and we will get to answering them at the end of the presentation. With that being said, we will now hand the floor over to Dr. Meliker for his presentation. Thank you.
Thanks, guys. So I am sharing the screen. Hopefully you see it. I'm going to talk a bit about cadmium and cardiovascular disease, but first I wanted to give you a little bit of a background on what is public health. And the American Public Health Association produced a really nice short video. So I'm going to play that for you. Full screen unavailable. Sorry about that.
We're not able to see the video.
You can't. Oh, sorry. Right. Let me share it again. Now it's working?
Yeah, we can see it. Thank you.
Public health is a vaccine that prevents disease.
Public health is a scientist who discovers the source of a salmonella outbreak.
Public health is outreach that helps prevent tobacco and drug use.
So what is public health? While a doctor treats individuals, public health looks at the health of a community. We research the risk of disease and injury in a population and take action to prevent them before they occur. Our early successes help stop the spread of infectious diseases by improving housing and sanitation. With a greater scientific understanding of health, well-being, and equity, we introduce prevention and early detection activities that help increase life expectancy by more than 20 years.
Public health is access to prenatal services for healthy babies and moms.
Public health is safety advances like seatbelt laws that have saved millions of lives.
Public health is access to contraception and education to prevent sexually transmitted diseases.
Public health was founded on the principle of social justice. As a basic right, everyone should have the opportunity for good health. But today, improvements in life expectancy have slowed, and we do not live as long as people in many other countries. Did you know? Only a small amount of what affects our health actually happens in the doctor's office. In fact, our health is mostly determined by the social and physical environments in which we live, learn, work, and play. Forget genetic code. A zip code can mean a difference in 15 or more years in life expectancy, even if you live a few miles apart. Nearly half of Americans live in communities with unhealthy levels of air pollution. And the Flint, Michigan lead crisis taught us the dangers of our aging water system. Poverty and poor health go hand in hand. Too many workers are denied a livable wage. They can't escape poverty and their health suffers. On-time high school graduation is a leading indicator of good health, but more than 20% of students miss this opportunity. Too many neighborhoods lack healthy, affordable food options like fresh fruits and vegetables. Addressing these complex health challenges will require cooperation across many sectors. Thankfully, public health has taken the lead in working with government, community organizations, and businesses.
We partner with city planners to design safe communities that encourage physical activity, bike paths, public transportation, and parks.
We support Medicare, Medicaid, CHIP, and the Affordable Care Act as steps to quality and affordable health care.
We advocate common sense measures to reduce gun violence. We can reduce gun deaths in the same way. We partnered with road planners and car engineers to address auto fatalities.
So what is public health? It is all of us, working together to make sure our communities are safe, prevent disease and injury, and give everyone the opportunities for good health. Join with APHA. We create the healthiest nation in one generation.
All right, so hopefully you think that's interesting. When you think about the factors that really drove differences in life expectancy from the start of the 20th century to really the start of the 21st century, medicine played a very small role, right? I mean, it was about vaccines, it's about developing vaccines, right? Research and then implementation of vaccines, a preventative on a global, global population level. It was about having safe drinking water, right? I mean, those two factors, were huge in terms of, life expectancy and quality of life. So just want you to have some perspective of there is a world out there besides medicine. A bit about my path is that I grew up in Baltimore and I attended Oberlin College. I wanted to go to a small liberal arts college. I thought it was a good place to really learn to think, which, I'm a professor at Stony Brook, which is a bigger university. I think the small liberal arts colleges do a better job of training undergrads to think. That being said, for grad school, I went to the University of Michigan, right, which is a top, internationally ranked university, and I went in their School of Public Health. In between that, I worked in Austin, Texas for a green building company called Center for Maximum Potential Building Systems. I also backpacked around the world for 9 months, $6,000 all inclusive. And after graduating from Michigan, I stayed in Ann Arbor where I worked for this really NIH-funded academic spinoff called BioMedware, which was developing software and applying the software. And I had some grants funded with them, and I have risen to the ranks now at Stony Brook to be a full professor. So that's a bit about my path, and I'm happy to answer any questions later, if you guys have questions about how I made decisions along the way. I want to talk to you for about 10 to 15 minutes, just a little bit about my research to give you a hint of it. The idea here is we're looking at urine cadmium as a biomarker of exposure to cadmium. And we're all exposed to cadmium because it's a natural element. If you smoke, you're exposed to it. But even if you don't smoke, just from the diet, it accumulates in fertilizer. It then accumulates in our food. It's everywhere. We all have cadmium in us. And one big question with any biomarker of exposure or of effect, anything that we're measuring, we want to know how good a one-time measurement is, right? That's why often you have fasting blood samples, because the measures are better if you fast. It's a more reliable measure. So we have this question with urine cadmium of whether or not, one-time measure is pretty good, indicative of average levels in the urine. And we had 2 cohorts. One was a reproductive cohort out in Utah, and another was first responders from the World Trade Center 9/11 event. And you can see we had 4 samples from this first study, and then a 5th sample a month later, and these were about 6 months apart, these 2 samples. And it didn't matter how much the time apart was. The ICC is a measure, it's called the intra-class correlation coefficient. It's very similar to a traditional correlation coefficient. So it lets us know that the correlation between samples is pretty good, somewhere between 0.66 and 0.78. So that is exceptionally good for an environmental biomarker. And if we keep going, we had another study in 2 older cohorts of men and women in the US, the 2 largest elderly cohorts in the country. And these samples were collected 4 to 6 years apart. And again, even 4 to 6 years apart, we had a correlation coefficient between 0.74 and 0.81, which is really, really good. I mean, it lets us know we can get by with a single sample. And that's part of what you need, right? You need to know if it's a representative sample, if you're only measuring it once, because it's expensive, right? So if you have to measure it more than once, it increases your costs. So now we can measure it just once. Plus, sometimes you can't get access to more than one sample. So we can measure it just once, and we also know a fair bit about what happens to cadmium in the body, right? It's bound by metallothionein once it enters the blood, and it's cleared by the kidneys and it accumulates in the kidneys. And what's really important about that is that then the amount that is excreted in the urine is in steady state with the concentration that's in the kidneys. So it really becomes this indication of long-term exposure. And this is very rare for environmental biomarkers. So we have a one-time measure of an indicator of long-term exposure. So it's great for doing research, right? So we're studying this in epidemiologic studies, observational epidemiologic studies, right? We don't randomly assign people exposure. It's unethical, but even it's wrong, right? I mean, regardless of what an ethics board says, you don't expose people to something that you think might harm them. So what we have to do is we have to observe them. And the easiest way to do it is cross-sectionally, right? Where it's just you recruit a bunch of people and you measure their cadmium and you ask them a bunch of questions, or you find out their medical records. But that's cross-sectional, and it's much stronger case if you can do something longitudinal. So we collaborated with colleagues in Denmark who run this Danish Diet, Cancer, and Health cohort to study the relationship between cadmium and these cardiovascular disease measures, these outcomes. And we were limiting this to never smokers because we didn't want smoking to confound the association. We know cadmium is associated with smoking. We know smoking is associated with cardiovascular disease. We wanted to make sure it was a cadmium effect that we were seeing and not a smoking effect. So we studied this in never smokers. And just to give you a sense of this cohort is 57,000 people, and they collected urine and blood on them all in the mid-90s. And the samples they're in a biobank. So we limited our participants to 19,000 never smokers, and then selected random subcohorts of 600 men and 600 women, and then these case populations of AMI, acute myocardial infarction, heart failure, and stroke. So we have 3 cardiovascular outcomes. So we collected the urine in the mid-90s. It's been in a biobank. We're measuring the urine now for cadmium, but these are levels that were in their urine from the mid-90s. And we're following these people into like 2015 to see if they developed these diseases. So all the diseases happened after they provided the urine sample. So it's a nice test of whether or not there is an association. It's not causal, but it's the closest thing you can get to causality in observational epidemiologic study. And I'm showing here the heart failure results, and the main results are suggestive. So this is called a hazard ratio, which is similar to a relative risk. If it's 1, it means that there is no association. What we see here is an association of 1.09. In the fully adjusted, it's 1.11. You can see the confidence interval does not include 1. The test for trend of these categories, where we had the reference category as the lowest quartile, comparing that to the 2nd, 3rd, and 4th quartile of urine cadmium, we do see an association. It's not statistically significant here. 1.29 does not include 1 in the confidence interval, but there is a significant test for trend. So it is suggestive that there is this association as cadmium goes up. So this one is as it goes up by about 0.19 microgram per gram. So that's really low levels in our urine. 0.19 micrograms per gram of creatinine. We use creatinine to standardize urine density, right? Because some people's urine is more yellow than other people's whenever you collect the sample. So you have to standardize it in some way. So it's micrograms per gram creatinine. We're seeing about a 11% increase in risk. And this basically takes us from the 1st quartile to the 4th quartile, this 0.19 microgram per gram. So we do see an association here. When we look at it for men and women, it's much stronger in men. We can see it goes up to 1.48 for the continuous, 1.99 looking at everybody in the 4th quartile compared to that reference quartile. And you can see it here. You can see the slope. It's a much stronger slope for men than it is for women. And for the full sample, it's something in between. So we do see this association, right? As your urine cadmium increases, we see an increased risk, increased hazard ratio for heart failure. And we had a bunch of sensitivity analyses because the question was, well, is creatinine what we want? How do we want to statistically or mathematically adjust for creatinine? So we initially just divided cadmium by creatinine, but you also can statistically adjust for creatinine in the model. Results very similar. There's another form of covariate adjusted creatinine standardization. Again, results very similar. All of these results are similar, and you can adjust for something other than creatinine called osmolality in the urine. Again, results very similar. So overall, we're seeing pretty significant, pretty consistent evidence of a significant association between urine cadmium and then incidence of heart failure. So that's important. With our other results, with AMI and with stroke, results were much less compelling. You can see the continuous, same interquartile range of 0.19 micrograms per gram, not significant, basically 1. It goes up a bit in the 4th quartile, but there's not a significant test for trend. It's greater than 0.05. And when we look at males and females here also, we are not seeing an association. Again, it's stronger in men, but at least in the 4th quartile, but overall not very strong. And similar, it got a bit more muddy when we looked at different sensitivity analyses. For the continuous, they're all consistent. It's always around 1. When we look at the 4th quartile, we do see a hint here for the statistical adjustment for creatinine, but it's not nearly as strong anywhere else. So we're guessing that's a false positive. We don't think that's a strong signal to interpret. And with stroke, again, no real association. You can see pretty close to 1 for the hazard ratio, test for trend, even less significant, 0.56. And when we look at it for males and females, stronger for males again, 1.18, 1.56 in the 4th quartile. But you can see, there's hardly much here in the spline model of the figure. So we're just not seeing much with stroke or with AMI, but we did see something with heart failure. And the question always is, well, what do you do with that? Before I conclude, let me just say, any observational epidemiologic study has the potential for confounding, right? There could be some factor that's contributing to the elevated urine cadmium that is also associated with later development of heart failure. But when it's a prospective study the way this is, it's pretty hard to think of what that would be. Smoking is the big one, but we controlled for smoking really well. We actually measured cotinine and we statistically adjusted for cotinine. We had information on secondhand smokes. We did a really nice job with tobacco smoke exposure assessment. We did a good job with the urine dilution. But there's always possible residual confounding. There's potential bias due to non-participation in the cohort, right? Not everybody who was invited participated, but it was population representative from 2 large cities in Denmark. There's always a chance that that there were people who would have gotten AMI or stroke who died, right? Or heart failure for that matter, who died prior to being included in the study. They died of something else. So it's possible that the cadmium caused something else. And since those people died and aren't included in our case population, but they would have eventually gone on to become a case, there's potential bias there, but it's very minor. Or it's likely very minor. And, just in general, assessing stroke and heart failure and acute myocardial infarction, the Danish data are excellent, but there's still, there's going to be misclassification, right? The definitions of these are never perfect, just like you're hearing with COVID deaths, right? It's never perfect. But overall, we do see an association with heart failure. There's strong mechanistic data, but the problem with the mechanistic data is that it's typically very high dose cadmium. But it shows that cadmium can be linked to cardiovascular disease via inflammatory pathways, epigenetic modifications, or endocrine disruption. cadmium exposure has also been linked with measures of left ventricular dysfunction, which we think is the most likely pathway for how cadmium might be impacting heart failure in particular. So that gives you a little bit of background on the type of work that I do and the types of studies that I do. Some of the current projects I'm working on is we've extended this cadmium project to also look at arsenic as well as nutrients, both in the urine and in food frequency questionnaires. So that's a mixture study, which is pretty popular right now. Another study is working with the 9/11 first responders. We're looking at some urine markers in relation to cognitive aging. So we'll see if that pans out. We have a hypothesis of specific urine metals, but it's a little too early to say if we're going to see anything there. And then another project was just funded that's looking at urine cadmium in relation to fracture and bone loss, where again, similar type of design, case cohort study design, prospective study. And I think it's going to be, it will be one of the definitive studies on whether or not cadmium is a risk factor for fractures and bone loss. So that gives you a sense of some of the work I'm doing. Here's a list of collaborators from really all over the country and to some extent the world, with my collaborators in Denmark. It just gives you a sense of how we do work now. It is a global endeavor. And with that, I'll thank you, and I'm happy to answer any questions.
Thank you so much for the amazing presentation. That was super insightful into your research. We really appreciate it. So with that being said, we will now begin the Q&A section. We will first start with the questions that were asked through the registration form, and then we will get to any questions that were asked in the Zoom chat. So this is your opportunity to ask questions, so please ask whatever you have in your mind. So the first question we got was, how would you describe the events that led to or followed the COVID-19 pandemic in relation to your work in identifying environmental factors that play important roles in disease morbidity?
Well, I mean, there's definitely work thinking about COVID and, its interactions with air pollution. There's questions about, initially, there were thoughts about whether, because of the stay-at-home both orders and just that people weren't going out regardless of what the orders were, there was less mobility, and people thought that would result in less air pollution. And some air pollutants did go down, but it was not uniform across the different types of air pollutants that we worry about. There's some evidence that perhaps air pollution, like if you're exposed to air pollution, you might have worse symptoms or worse risk of death from COVID, but that's still very much, under research right now. And so it's too early to say anything about that. I would say strongly say anything about that. In terms of me, I did not do a lot with environment and COVID, but I did a lot with COVID because there's a lot going on, right? I mean, I was interviewed by Newsday, which is what, the 10th or 11th highest circulating paper in the country. I was one of the few, I'm one of the few epidemiologists on Long Island, and we were one of the hotspots early. I think I was interviewed by Newsday at one point. It was weekly in the initial spring. They just wanted to get my take on it. So definitely we were staying abreast of it. I was also very concerned about the ancillary effects, right? So if people are missing school, what are the effects of that, right? Like, should we have closed schools? I think is a very important question that needs to be looked at, right? Even if we didn't technically officially close schools, for many communities, the only option was to close schools because the requirements were too stringent to be able to run a school. So there definitely were a lot of COVID related questions that are about COVID, but also about the impacts of the response to COVID. And I think we need a lot of work in that area. We also need a lot of work in the area of communication, right? Like how we communicate effectively to the public, because right now, I would say public health is losing the communication battle with COVID. I mean, maybe we're not losing it because a lot of people have been vaccinated, but there's still 10, I mean, where I am, I think it's 10 to 15% of adults that still have chosen not to get vaccinated. And the more people you get vaccinated, I mean, you can look at Portugal. Portugal leads the nation, leads the world in vaccinations. Look at their case numbers, compare them with the rest of Europe, and compare them with nearby countries. I mean, it's clear, right? If you vaccinate, you're reducing the spread and reducing the number of cases. It's undoubtedly clear. Anyone who works in a hospital knows this, because the numbers in the hospital, most of the cases are unvaccinated.
Thank you so much for that amazing answer. And the next question we have was, what do you think is the most helpful degree for medical school?
I mean, I'm a professor in a school of medicine, but I did not go to medical school, so I am probably not the best person to answer that question. I think in general, if you want to go to medical school, you should figure out why, and figure out what types of jobs you want. But I also think the more you understand about social determinants of health, about the upstream causes of health, the better. So I mean, my opinion is just about everybody who's a doctor should probably have some public health training in some way. At least some sociology training, some training in ethics. There have been lots of, I mean, there's been a lot that's gone on in recent years of doctors being paid by pharmaceutical companies to tout pharmaceuticals, and basically because of ethics violations, now the whole field is requiring everybody to go through a tremendous amount of ethics training. And frankly, these violations should never have happened. And I think they're happening because, in part, people they're not trained broadly, right? There are too many people who are only trained in the biomedical sciences who go on to be doctors, and really doctors should be much more than that.
Thank you for that answer. Super insightful. And a really quick side note, we do see all the questions in the chat. We're going to get to them at the end of the registration questions. So thank you for all those questions. So the next question is more of a personal question. So how much spare time do you have for yourself, and what do you enjoy doing in your spare time?
So, I mean, I think it all depends what point in your career you are as to how much time you have. When you're on the tenure track and you're learning to really write papers and write grant proposals, I don't think you have as much time. Sometimes, I mean, right now I have a lot of grants, so it means that I don't have as much time. But I'm a parent. I have an 8-year-old and a 14-year-old, so my time is spent basically parenting, right? I mean, that's how my spare time is spent. But I'm home for dinner every night. We have dinner together every night, unless I'm teaching or at a conference or at a grant review panel, doing something away.
Okay, and the next question we had was, what made you want to go into your line of work?
So I was thinking about both environmental design and environmental health. In college, there was a speaker who talked about Parkinson's disease and potentially its links with pesticide exposure. So that led me to first think about links between environment and health. When I worked in Austin, Texas for the Center for Maximum Potential Building Systems, we had a demonstration home for the green building in the state of Texas we were working on. And there were always offsetting risks, right? Just like with COVID now, where you have the offsetting risks, right? Do you keep everybody home? What do? You have offsetting risks. There we had questions of, some of the materials that we were using they may have been sustainably harvested or sustainably produced in some way, when we think of environment, but there may have been some toxics in there as well. So trying to be able to understand the offsetting risks. And as you will learn, there is so much uncertain about environmental contaminants. There's natural contaminants, and then there's the anthropogenic created contaminants. I think there's estimates of somewhere around 100,000 different chemicals that we have manufactured and only around 3% of those have ever gone through rigorous testing for risk. So we are all guinea pigs all the time. Don't let anybody tell you you're a guinea pig just because of a vaccine. We're guinea pigs all the time. And that is the deal that we have made with modern industry, right? Essentially, because we said we want new technology as quickly as possible. You don't have to tell me whether or not the flame retardants you spray on my phone are going to, cause me health problems, right? You don't need to do that. We don't need to assess that because nobody's eating their phone. Even though you might be exposed and you're certainly accumulating the flame retardants, we don't need to show whether or not there's risk there. So we've made this deal. And, that really pushed me, becoming aware of that pushed me to really think about trying to understand risk from contaminants in a much better way.
Thank you so much for that answer. So the next question we got through the registration form was, in your opinion, what is the greatest experience you have had in your career?
Yeah, that one, I remember that one when you sent it along. That's a tough one to say. It's the greatest in my career. Definitely being recognized for your work is nice, right? When you get invited to be on NIH review panels, when you get invited to be a member of a steering committee for an international conference, when your students go on and do great things. Those are all good things that happen. So I don't know if there's a greatest, but those are examples of different good things that happen.
And we also have the next question, which is about pretty much the opposite, which is what are some of the struggles you have faced in your career?
The struggles, I'm trying to think, the biggest struggles I have now are really around just management of projects, right? That officially, so NIH will fund grants, and they'll give you, they might give you millions of dollars to do a project, say, and then the university gets another 50% or so of that on top of that to help, give you space to do it, but also they're supposed to, help you manage the grant work. The problem, as often happens at most universities, is they don't help very much with the grant administration. So I'm in a situation where I have to juggle making sure the subcontracts are up, making sure the invoices are paid. And it's a big institution. So it just requires, it's not like you just walk down the hall to find someone who's going to do it. It's all the way across campus to make sure these things are working. So it requires either picking up the phone, or you send an email and then the email doesn't get responded to and you have to keep track of that. There's just a lot of administration and management. And that is not what I want to be doing, right? I'm a scientist. So that's probably my biggest frustration and challenge right now, is figuring out how to administer grants in a way that, makes my work more enjoyable.
Thank you so much for that. And the final question that we received through the registration form was, how has COVID-19 affected your current career?
Well, it's impacted my career as a parent in that, my kids were off for 6 months, basically. And then we were still working from home really much of last year. So it's definitely impacted my life in that way. Scientifically, it's impacted my life just in that, we do have some papers that we're working on. We had one that I think is about to be accepted. So there have been some papers that we've done and continue to work on. Again, trying to understand a little bit of some of the additional offsetting risks, looking at domestic violence, whether or not that went up during stay-at-home orders, things like that, depression, anxiety, how that was impacted. So yeah, both personally and professionally, it has impacted, things that I'm doing for sure.
Okay, thank you so much for that. And now for the first Zoom question we got, which was what's your professional opinion about the booster shots for COVID-19?
So if you read closely, I mean, I didn't read it closely, but Paul Offit, who's an expert in vaccines and immunology at University of Pennsylvania Children's Hospital, I saw him give a talk, and he's on the advisory committee to FDA. Pretty sure it's FDA, not CDC, but that assesses these things. And he said really the evidence isn't that strong that most people need boosters. Um, and I tend to agree with what I've seen. There's definitely a difference in the population in that some people aren't building up as much immunity as other people from the shots. But I don't know if we can know for certain whether or not a third booster is going to help them. And I think that's still something that we need to do more work on. I'm not fully convinced. I haven't seen the data yet because there are individuals, especially above age 60, 65, who are getting COVID after being vaccinated. It's more common among that age group, and it's more common that it's severe among that age group. So a question that's still outstanding is what will happen after they've been boosted. After they've been given the booster, will it protect them? Will it give them greater protection? And I think we just don't know that yet. We don't know the answer yet. There's no doubt that it ups the antibody levels that we can measure, but whether or not that really gives added protection or for how long, I think we don't know. Now, long term, I could definitely imagine a world where we are getting boosters somewhat regularly, because there might be waning immunity from the vaccine, or from past infection. I mean, we already know from past infection there's waning immunity, but there might be waning immunity from the vaccine as well. I think we don't fully know enough yet. It's still it's a new disease, so it's going to keep evolving, and you have to accept that the science is going to keep evolving.
Yeah, thank you so much for that in-depth answer. So the next question is very similar to a different question. So there's two very similar questions. So I'm just going to ask one of them. So regarding your research, what factor causes women to have a weaker result than men in the relationship between cadmium and heart failure?
Yeah, no, it's a great question. We don't fully know, but we do know that there are risk factors for cardiovascular disease that are different between men and women. So I forget, I don't have a list of what they are, but there is a list out there. If you do just a quick Google search, you'll see that there are differences. And it just could be that there are differences here. But we don't know. We don't have good intuition as to why that would be. We were more stratifying by men and women initially. I mean, well, we stratified because we know that risk factors are different, for cardiovascular disease between men and women, but also because the creatinine levels tend to be higher in men than in women. So when you control for creatinine, it can impact, the association that you see if you have men and women together in the same sample. So that's one reason that we stratified by men and women to analyze them separately. But yeah, we don't have good instincts as to why, and it's a great question.
Yeah, that was a very insightful response. So thank you so much for that. And our next question was, how do you decide whether medicine is a future path for you or not?
So for me, I was never really tempted to go into medicine. To me, it was always, I mean, if you read the history of medicine, up until, the early 20th century, most doctors caused more disease than they helped prevent because there was no way to wash your hands, right? There was no cleanliness. So it was just one, they would go see a patient and then they transferred whatever disease they had to the next patient. There's great books on this. So, when you look at, again, what's made the most impact on people's overall life expectancy, it's been preventive measures, it's been vaccines, it's been, clean drinking water, wastewater management. Um, so it never really, I never really thought it would be that interesting to be a doctor. I think at least not from a gain to society perspective. It's definitely, you can make impacts on individuals' lives. There's no doubt about it. And I think, I've had multiple surgeries for orthopedics problems. And I think, I'm really glad there's orthopedic surgeons out there, to be able to help me. I'm glad there's, cancer specialists to be able to help with cancer, cardiovascular specialists, and so on. But it just wasn't something that I ever thought about doing. I was much more interested in trying to identify the, big factors and then make impacts on a population level.
Thank you so much for that response. So a little bit earlier in the presentation, you mentioned that public health communications were poor. So the question this student asked was, how do you think that national public health communications can be improved?
Yeah, it's a great question. I mean, I think I have an opinion which is currently not terribly popular. And it is that I don't think we should ever say anything is safe, because nothing is 100% safe, right? Walking across the street is not 100% safe. You never know when something bad is going to happen, right? There's always some degree of risk in everything. It's all about offsetting risks and probabilities. And the problem is that is hard for people to understand. So the question is, do we need to be able to train people, train the population better to understand that science is not a collection of facts, right? At least when I was in high school, that's how it was taught. That is not what science is. Science is a process for accumulating knowledge, and the process can result in knowledge that evolves over time. And especially with new diseases, you would expect that with something like COVID. So you would expect the responses to evolve over time. You'd be surprised if they didn't. Yet everyone says, oh, nobody knows what they're talking about because they keep changing their mind about things. Yeah, but that's what happens with science, right? I mean, you follow the data and you need to design the studies the right way, but we need to be able to communicate that effectively to the population. And that's something that currently we're not doing at all. We're trying to sell everything as though it's definite and it's true. And there's no definite or true. It's just, this is what the data points us to at this point in time.
Thank you so much for that very informative response. And what we have next is what helped you determine which field of study you wanted to pursue.
Yeah, I mean, so I majored in neuroscience because I was interested in how the brain worked. I minored in environmental studies because I was always worried about the environment. So linking the two in some way made a lot of sense. I also, while I was at Oberlin, we were designing a new green building, and that was really neat. So I was very interested in environmental design, questions about how to design things more sustainably and more environmentally friendly. So I was thinking, I was really torn between environmental health, right? Environmental contaminants and disease, and environmental design, designing products or designing systems in a more sustainable way. And I applied to programs for both. I ended up going to Michigan because they paid me. They gave me money to get my master's, right? I was going to go to Berkeley and I was going to do a dual master's in public health and environmental design. And instead, I went to Michigan for public health. I wasn't as keen on their environmental design program back in the late 90s when I went to grad school. And, basically that decided which way I went. Michigan was a great school, so I was happy going there, and I just followed the opportunities that presented themselves there. And that was much more aligned with environmental health. And it's been good.
So the next question we have was, how do you find research opportunities for high school students?
So, yeah, I mean, I have a lot of high school students who contact me. Some we've had funded through the Simons program, which is at Stony Brook University. Jim Simons is a program where high school students from around the country come. Some are doing it as part of their, research experience in high school, where they're learning a little bit about how to do research. And I just put them on different projects. I put them on a project sometimes, that we're working on with some of the COVID stuff. We've had high school students lead, where it's like, we started some projects, and as people contacted us, we opened up opportunities for them. I mean, that's the best I can answer it. And sometimes it works and sometimes it doesn't. Sometimes the high school students flourish. I think I've published at least 2 papers with high school students, maybe 3 now. But for every paper that's been published, there's been high school students, 1 or 2 high school students who haven't been able to publish any papers. So it just depends on the student.
And for the final Zoom question that we have is, how does public health vary on a global scale? And what do you think is a predominant factor that drives these differences?
I mean, sure. I mean, globally, right? I mean, there's going to be different problems. If you're looking at the drivers of disease, the determinants of disease will vary geographically, as well as the types of diseases are going to vary geographically, right? If we look at globally, I think still numbers wise, if you want to impact people's lives on this planet, the number one thing to do is to deal with water, right? Clean drinking water, safe way to dispose of our excrement, right? I mean, those are the things that we need to do to impact people's lives globally. I mean, those are the dominant things that we need to do at this point. There's definitely other infectious diseases, which are still big problems, malaria, schistosomiasis. There are diseases that we should be managing better on a global scale. In terms of, other predictors of health and well-being, there's definitely factors along, the social determinants of health dimension, where we think about class, we think about race, we think about opportunities, think about racism, right? I mean, those are definite factors that impact, different groups all around the world as well. So yeah, there's different ways of thinking about it, whether you want to think about it from a determinants of health standpoint or from a disease standpoint. From an environmental standpoint, we think about air pollution, we think about occupational exposures and risks, we still think about lead a lot globally, and lead pollution, lead poisoning.
So yeah, thank you so much for all those amazing answers. And we would once again like to thank Dr. Meliker for taking his time today to give us an introduction to his research. And thank you all for attending today's presentation. Please use the link posted in chat to obtain your shadowing certificate. And thank you all for attending this meeting today. And we look forward to seeing you in our next monthly meeting. We're going to be sticking around for a couple more minutes to make sure that everyone has access to the link.